Today, we look at hemostasis, important topic for you, your profession, and a rather complex process. For the purpose of understanding, we will have several videos on this topic from the very early stages of hemostasis to its final stage. So the first one is to learn about the definitions, then the early parts of the process of hemostasis. A literal meaning of hemostasis. Look at the term hemo refers to blood. Stasis is standing. Arrest of bleeding or stoppage of bleeding is what that means. So in a typical situation, when there is vascular trauma via injury or through surgical intervention, first thing that you notice is the endothelium is damaged. Okay, endothelium serves as a barrier in preventing the attachment of platelets to the blood vessel wall and interacting with the proteins in the deeper part of the vessel. For example, collagen fibers in the deeper layers of the vessel wall is highly thrombogenic, means it triggers blood clotting. And so endothelium blocks the interaction between platelets and collagen fibers. But when there is injury, that barrier is lost. Therefore, platelets are now able to interact with the collagen fibers. So there is that chance of blood clot formation. So how does it all happen is simplified here. Injury initially leads to loss of blood, and then through the formation of a clot, there is that arrest of bleeding. The clot formation is good temporarily, but then has to be removed ultimately, and that's clot dissolution. So these are the few steps that we want to understand. So let's go to the next slide, where we talk about what prevents the development of blood clot in a typical situation. Why doesn't the blood clot all the time? So we already talked about the endothelial barrier and how it interferes between the platelets and the collagen fibers. Secondly, there are chemical agents that are present in circulation. And some examples are shown here. Nitric oxide is one, prostacyclin is another one. Prostacyclin is a prostaglandin. And both these agents are vasodilators. Okay, so when the blood vessel dilates, platelets move easily through the vessel, less interaction between the platelets and the vessel wall. All right, then these agents are made by endothelial cells themselves, and their main function is to inhibit platelet adhesion and aggregation. Aggregation is like forming a lump of platelets, and then the binding of fibrinogen. Fibrinogen could be the link for platelets to attach to the strand and then form that aggregate. All right, so all these are avoided in the presence of nitric oxide and prostacyclin. All right, then the other set of agents are anticoagulants. As the name suggests, they inhibit the action of clotting factors. Some examples are shown here, not all. Antithrombin 3, which is made in the liver. It's a plasma protein, and as the name suggests, it inhibits the action of several clotting agents. Factor 2 is thrombin, and then 9, 10, 11, and 12. So basically, the intrinsic pathway and the common pathway could all be blocked by the presence of antithrombin 3. Yet another agent is a tissue factor pathway inhibitor. Okay, TFPI. This agent is made by endothelial cells themselves, and it inhibits tissue factor. Tissue factor is one of the agents that's needed in the extrinsic pathway, and that is inhibited. So you are talking about the inhibition of extrinsic pathway by one agent, or intrinsic and common pathways by another agent, and so on. Okay, so these are just examples, and there are many more such agents present in the body to prevent the production of blood clot unnecessarily. All right. Now let's understand the basic details. What is needed? What is involved in hemostasis? Of course, blood vessels. It happens within the blood vessels. And what's the role of blood vessels here? Well, vasoconstriction is one. Okay, as soon as the vessel experiences trauma, there is vasoconstriction. It's an autonomic response, a very quick response, and that leads to narrowing of the vessel. Narrowing of the vessel is to limit the loss of blood. Then, due to trauma, you would expect the expression of various agents like the receptors, clotting agents, and loss of certain other things. So here you're talking about procoagulant factors. You're talking about the release of certain clotting agents in the inactive states. Okay, loss of anticoagulation pathways. So it goes in the opposite ways. You need clotting agents, but you do not need anti-clotting agents in order to make the blood clot. All right, so all of that happens within the blood vessel. Then platelets are the other key players. You will learn a lot of detail about platelets very soon, so we will wait until then. But platelets are the ones that form the clot. They release chemicals, they release clotting agents, then they cling to one another, they're activated. You know, there are so many things that you need to learn about platelets here. And then last but not the least, clotting agents or clotting factors. You have approximately a dozen of these factors that are activated in a series, pretty much. Activation of one clotting agent would lead to the activation of the next, and another one, and so on. Okay, and clotting factors make up two different pathways, are actually three different pathways: intrinsic, extrinsic, and common pathway. All right, with this knowledge, we will organize the event of hemostasis into three different steps in the order it occurs. Okay, this is just for the purpose of understanding. So let's talk about what exactly happens immediately, what would happen next, and how does it all end in a blood clot. Okay, so here is the injury or a surgery In other words, it's a trauma to the blood vessel. All right, so the immediate response would be vasoconstriction, and the time it takes is 1 to 2 seconds. And as I mentioned, it's an autonomic reflex. Then the next step you see is the attachment of platelets. Adherence is the attachment of platelets to the blood vessel wall, the sites of endothelial lining disruption. You see, endothelial lining is now displaced, and now the collagen fibers are exposed. Attachment of platelets to the collagen fibers would activate platelets. Activated platelets become bigger and spiky, and they release a number of chemicals, and these chemicals can make the surface be sticky and also attract more platelets to the site. So that's what you call as recruitment of more platelets. And this process is a positive feedback effect, where new platelets arrive and they're activated, they release chemicals, and that would attract even more platelets. So that is the amplification stage. Then platelet aggregation. So because of the arrival of a large number of platelets to this one area of injury, there is that group or a mound of platelets in one particular place, and that's what you call as a platelet plug. And this is the first form of a clot. It's not a real clot. It's not made of clotting agents. It's just the accumulation of platelets. But in a smaller vessel, this could prevent blood loss temporarily. So you can call this as a primary clot, but it's unstable clot. And the time it takes is approximately 20 seconds. Now, the next step, and the step that takes much longer, would be the involvement of clotting factors. So activation of clotting agents, and then the actual production of a more solid type of clot, and that is more stable and a secondary clot. Okay, and it happens eventually. So first thing is a constriction. Second thing is a temporary plug, the platelet plug, and then a more permanent plug, that is the clot. And because it takes longer, it's like the duration is 2 to 6 minutes. Now, never assume that the clot is going to be a permanent structure. That won't be good if you have the clot in place permanently, because then it interferes with blood flow and decreased blood supply or no blood supply to the adjacent area, and that's not a good situation. So what happens is this clot will be broken down eventually. Okay, it's a process where clot is formed, and then the repair of the vessel would begin right away. And then as the blood vessel gets repaired, the clot dissolution or removal of the clot through the breakdown of fibrin strands will begin. Okay, so the clot will be gone. This is just a summary of what happens in an animated fashion during hemostasis. So step one is when there is injury, that trauma we talk about within the blood vessel, there is that loss of blood. And what do we see here? Arrival of platelets, attachment of those in the blood vessel wall. The opening is now becoming narrower, and therefore there should be less blood loss. And Step 3 is where you begin to see the presence of these strands. These are fibrin strands. What that tells us is clotting agents are activated, and these agents would convert fibrinogen to fibrin. And that's the early stage of fibrin strands being present. And now the fibrin strands are forming this loose mesh that occludes the vessel and then prevents blood loss. So the clot is in place, and the next step is to remove the clot. Once the repair is completed, you notice that the strand, the long black lines, is now all dots. These dots are broken down fibrin strands. Okay, so that is how you get rid of the clot. That's what you call as clot retraction. Now, there is another theory to explain this process. This is just a new idea, that is cell-based theory of coagulation. What it talks about is the same process, that is the 3 phases, but here you give different names: initiation, amplification, and propagation. What happens in the initiation? You basically now get rid of the anticoagulants, and then tissue factor promotes binding of platelets to the endothelial surface. You know, when there is injury, there is injury to the tissue within that area, and there is that one particular agent, tissue factor, that is released and that binds to platelets and allow them to interact with collagen fibers, and that would promote the activation of platelets. So that's the first step. That's what you call as initiation. And the same tissue factor would downregulate anti-clotting factors. That means there are less anti-clotting agents to protect the vessel from the formation of a clot. Second step is amplification. So this is where you're beginning to activate the clotting agents. Propagation is where everything is now turned on. Propagation is clotting process will continue. All right, so that's what you're looking at. All right, very basic details about platelets. This is a good review here. So let's see what it is. You're talking about the bone marrow, stem cell, which gives rise to one young cell, megakaryoblast. By the way, the hormone that you see, thrombopoietin, is the one that influences the activation of the stem cell to differentiate into megakaryoblast, which ultimately matures, and now it's called megakaryocyte, mature cell, bigger than it was when it was originally formed. And what it does is to shed its cytoplasm. These little fragments that you see are nothing but the cytoplasm of megakaryocyte, and they are released into blood. Okay, so these are now referred to as platelets. So small cytoplasmic fragments of megakaryocyte are referred to as platelets. All right, so these are not real cells. All right, they're called thrombocytes. Thrombocytes are not real cells. They're just a tiny fragment of megakaryocytes, about 2,000 or so per megakaryocyte is how it is. And when a megakaryocyte loses its cytoplasm, it's not going to survive, and it's replaced by new megakaryocyte, and that would add to the new platelets as needed. So now some other details about platelets. Platelets number is shown here. Each book would have its own range of numbers. So if you see 400,000 or 450,000, you do not have to panic. All right, so approximately 150 to 350,000 per microliter. It's very small, 2 to 4 micron in its diameter, and then its survival is only about 8 to 10 days. Now, again, that range could be 6 to 12 days in some other books. Again, just ignore. Now, it contains a number of chemical substances and a few cell organelles. The organelles that it has is secretory vesicles, ribosomes, mitochondria. But then it has a variety of granules, dense granules, alpha granules. It also has calcium ion. All right. Now let's think about what dense granules are made of: ADP, ATP, serotonin, histamine, epinephrine. Some of these, like ADP and serotonin, may trigger vasoconstriction, and epinephrine, as you know, does too. Alpha granules would contain one Willebrand factor, VWF. It's a very important factor. It's not only made in the platelets, but also from the endothelial cells. All right. Then fibrinogen, fibrinonectin. This is the one that stabilizes the attachment of platelets to fibrinogen. So these are all different agents that are present within the platelets. A platelet factor 4 or PF4, platelet growth factor, and note here contractile proteins such as actin and myosin. They again stabilize the binding of a platelet and then the platelet plug position. Okay, so that's a long list of agents that are present in the platelets. All right, so now it again secretes one prostaglandin, thromboxane A2. All right, we saw prostacyclin before. Now we are talking about thromboxane A2. It's another prostaglandin. All right, its role is in the attraction or activation of platelets. You see, whereas prostacyclin is the opposite. It would inhibit the attachment of platelets to the wall. Okay, but thromboxane A2 does the opposite. It's important in the attraction of platelets, or that is recruitment of platelets, or the activation of platelets, which leads to the production of a blood clot. All right. Then platelets have the ability to make thrombin, prostaglandins, procoagulants. Some clotting agents are released by the activated platelets. Anticoagulants, fibrinolytics, those are the ones that break the clot, and then activated platelets display membrane receptors. Okay, a number of receptors appear on activated platelets. Platelets attach to collagen through VWF. Okay, so that's a very important function of VWF. That's the Van Willebrand factor. Okay, as I mentioned, this factor is made not only by the platelets but also by the endothelial cells. Okay, so with this, let's talk about the very first step, that is vasoconstriction. In the hemostasis, the first thing that happens is vasoconstriction. This is just a basic illustration of an injury here and vasoconstriction. That's the narrowing of the vessel. If it was a small vessel, that may be sufficient to prevent blood loss. The chemicals that are released by the activated platelets would continue to cause vasoconstriction, and as it happens, you would refer to it as vascular spasm, because you're causing this vasoconstriction at certain intervals. All right, so that's all you really want to know about this. It's an autonomic reflex. There is injury, then there is vasoconstriction. It takes place in no time, pretty much 1 to 2 seconds. All right, with this, let's go to the next step, and a more important step. This is where we talk about platelet plug formation. This is our intermediate step. All right, so let's understand this here. There are a lot of details for us to go through, and you have to be careful about these details. So there is injury. Now the exposure of the subendothelial layer, that is the deeper layer of the blood vessel wall, is now exposed. All right, all of a sudden you see VWF appear in the endothelial lining. Okay, it just happens to be there. Remember, it's made by the endothelial cells. So injured endothelial layer may promote the expression of VWF. And another receptor that appears is GP1B, glycoprotein is what GP stands for, 1B receptor on a platelet surface. So you have the platelet here with GP1B, you have the endothelial lining with VWF. Okay, so what happens is this is platelet, this is VWF. VWF binds to GP1B on the platelet, and then VWF binds to endothelial surface. So now basically you're connecting platelet to the collagen fiber, or the deeper part of the vessel wall. All right, so this type of link is made by VWF. Okay, GP1B bind to VWF to let platelets adhere to the site of injury. So this is how you attach the platelet. Attachment of the platelet to the wall that doesn't have the endothelial lining would lead to activation of platelets. Remember, collagen fibers are thrombogenic. As soon as platelets attach to collagen fibers, they would be activated. Now, expression of platelet surface receptors. So more receptors would be expressed in the activated platelets. Now you're talking about new set of receptors, GP2B, GP3A complex. Okay, so these two receptor complexes would link activated platelets together. So now activated platelet here, activated platelet there, they are interconnected. So you're talking about 2 platelets attached to one another, 3 platelets attached to one another, and more and more and more. Platelet aggregation is the collection of platelets all in one small area. And that leads to the production of a platelet plug. That's what you call as a primary clot. And in the small vessel, it would may be sufficient to seal the site of injury, but not in large vessels. So that's again a simple illustration of how platelets will be activated, and now they're swollen, they're spiky, and they form this plug blocking the area and preventing blood loss. All right, so with that, let's move on to talk about activation of platelets in detail. This is where you talk about VWF on the blood vessel wall. This is the disrupted endothelial surface. Maybe there is a cut here. And now you're talking about a platelet with GP1B. And then you're talking about other receptors that are expressed. This is GP2B, GP3A complex, which would help link one plate to another via fibrinogen. This blue strand that you see is fibrinogen. What it's doing is to connect one platelet to another, and so on. So this is now a combination of many platelets. Activated platelets release chemicals which attract more platelets to arrive, and their expression of receptors, their release of chemicals, and their sticky surface make them attach to these original set of platelets, and that's how you have the arrival of several platelets and the platelet plug formation. So let's go through the details here. Aggregated platelets expose factors on their surface, so expression of a number of factors that would lead to activation of platelets. So you have to remember this term activation. If you look at the previous one, I have highlighted quite a few things here. Once you have exposed the subendothelial layer to the platelets, there is adherence, okay, activation, aggregation, platelet plug formation, okay. AAAP is how you probably want to remember. Attachment first, activation next. That leads to aggregation of platelets, and then that's what you refer to as platelet plug. You could say the AAA leads to the formation of a platelet plug. That works, right? So now let's talk about other details here. Inflammatory agents also contribute to platelet activation. That's true. Inflammatory agents. So whenever there is injury, there is inflammation, there are a number of chemicals released in this particular process, and that could also lead to platelet activation. And that now causes swelling of platelets, display of receptors such as GP1B, GP2B, GP3A, and all these would then trigger the release of a variety of chemicals, ADP and thromboxane A2. All right, so these are all pro-coagulation. ADP is a vasoconstrictor. ADP is now going to make the surface sticky, and then thromboxane A2, as you already learned, will help attach the platelets, create the aggregation of these platelets, right? Expose fibrinogen receptors on the platelet surface. So this is what you're talking about, fibrinogen on the platelet surface. So it binds to fibrinogen receptors. So fibrinogen, which is factor 1, attaches to its receptors and link platelets to each other. That's what you're looking at here is the strand, fibrinogen. It links other platelets. Platelet plug is formed in this fashion. Activation of new platelets by the chemicals released by these platelets, cross-linking of more platelets, and that's what you call as a positive feedback effect. And basically, you know that a platelet plug or a primary clot is formed. Good. Now we are talking about molecular mechanisms, basically much more detailed steps that are involved in the activation of platelets. So we compare here the normal situation to the situation where there is surgery or another type of vascular trauma. Okay, in a normal situation, okay, the blood vessel prevents platelet activation through the secretion of anticoagulating agents, anti-adhering agents. We talked about several of these already. Okay, antithrombin 3 we talked about, anti-adhering agents like prostacyclin, nitric oxide, remember, and a balance between vasodilator and vasoconstrictor agents. Now, whenever the opposite is true, that is when the vessel is damaged, there is activation of platelets. We know all the steps that are involved in the activation of platelets. adherence of these platelets. Now, activation of GPCR, that is G protein cell receptor activation. Okay. So now G protein activation results. Okay. Well, what activates G protein is what you need to know. A number of agents that are released by the platelets, or the inflammatory agents that are released locally, could turn on the activation of G protein. Okay. So what mechanism does it use when you have turned on the G protein activation? Okay, the mechanism that you see here typically is the presence of phospholipase C. Okay, phospholipase C is an enzyme, a membrane enzyme that's activated by the binding of one of these agents to the G protein cell receptor. Okay. So when one of these agents bind to the receptor on the cell membrane, activate the G protein, which in turn activates phospholipase C. That's what you have understood so far. So activation of phospholipase C could lead to one of these three steps, or many of these steps. So let's understand each one. Inositol triphosphate, IP3, is released in one instance. IP3 is released. This is the one that triggers the opening of calcium channels. So calcium ions are released, whether this is intracellular or extracellular. So more calcium is in the cytoplasm. And what does calcium do here? That's going to release the agents that are present as dense granules and alpha granules within the platelets. Now, the release of these chemicals would attract more platelets and the activation of more platelets. So that's positive feedback effect. Okay, so presence of IP3 in the presence of phospholipase C could lead to arrival of more calcium ion. More calcium means more release of chemicals through these granules. These chemicals would attract more platelets. The second chemical that you would possibly expect with phospholipase C is diacylglycerol, DAG, and protein kinase C, PKC. All right, so the presence of these two agents within the cell, now you're talking about PKC, intracellularly could trigger the arrangement of proteins in different ways, change of shape because of the rearrangement of the platelet cytoskeleton to better bind VWF, see? And then that results in spiky shape. Now, yet another response in the presence of phospholipase C is the release of arachidonic acid. All right, so this is basically a lipid molecule. Now, it can get converted in the presence of cyclooxygenase 1. You also call it as COX-1. That's the one that converts arachidonic acid to thromboxane A2. Remember, thromboxane A2 promotes attachment and aggregation of platelets. So, in the presence of phospholipase C, you could convert arachidonic acid to thromboxane A2. All right, so it's all related to activation of platelets, which will ultimately lead to the production of a clot. Okay, so this is where you could talk about use of aspirin and how that could interfere with this production of thromboxane A2. That's where acquired aggregation disorder will be discussed. So if cyclooxygenase, that's COX-1, is acetylated, meaning no one chemical reaction here, it's now going to be inactive. Okay. Aspirin does that. Aspirin makes the COX-1 non-functional. Non-functional means you cannot convert arachidonic acid to thromboxane A2. You see? So it's a permanent effect, and that would prevent platelet aggregation. Okay, aspirin is not recommended for people with bleeding conditions. Why? Because here it would prevent the blood clot production. How is what you're looking at? It inactivates COX-1, so you cannot make thromboxane A2, which promotes platelet aggregation. All right, a similar effect is noticed with NSAIDs. Okay, non-steroidal anti-inflammatory drugs, NSAIDs, like ibuprofen. This is a temporary effect, by the way, which lasts about 1 to 4 days, a temporary effect. All right, again, the same effect in activation of COX-1. All right, now there is another agent, Plavix. It's also used commonly. It's an anti-ADP agent. Anti-ADP agent does the same thing. It would prevent the production of thromboxane A2, permanent effect. All right, so that's one discussion. That is how you could have the aggregation disorder. This is the platelet aggregation is not going to happen. Acquired meaning by taking these medications, you're interfering with the process of blood clotting by not being able to produce thromboxane A2. Okay, good. Well, this is just a common thing to look at here. Adhesion in different types of blood vessels. What happens in the vein, what happens in the artery, what happens in the capillary when you think about adhesion. All right, blood flowing through the vein, as you know, will take its time, move slowly, and if you're stagnant, like you are taking a long flight, not able to move around much, then what happens is blood is pooled, and then platelets are able to interact with collagen. So now collagen adherence is favored by poor venous circulation, right? So that's what you call as deep vein thrombosis, DVT. Arterial blood flow, on the other hand, is where you have one Willebrand factor, as you already know, links collagen fibers to platelets and allow their attachment to the vessel, activation, aggregation, and all that. All right, it's a major adherence anchor. A capillary blood flow, there it's not common for adhesion. Okay, red blood cells push platelets to the side. Okay, so there is not much collagen fiber in the first place because there is just the endothelial lining in the basement membrane, no collagen fibers to worry about. So that's where it's not common for you to expect any adhesion and occlusion. Okay. A very common condition, an inherited common condition, is von Willebrand disease. So let's take a look at what happens without the VWF, increased bleeding time. Platelet count will not be affected, as you know. The number of platelets is not an issue here. It's the link between platelet and the collagen fibers that is not able to happen, not able to work as normal, right? Abnormal binding of VWF to platelet receptors or insufficient production of VWF is the cause of this disease, okay? Now you are looking at a way to treat DDAVP, that is ADH, or arginine vasopressin is how you call it. Its pharmaceutical name, clinical name is desmopressin, is the one that improves platelet adhesion. In the condition of von Willebrand's disease, patients will be given DDAVP, desmopressin, that promotes platelet adhesion. Okay, so that's where we stop. The next video is going to be all about clotting factors and how a clot is produced. All right, we will come back to this topic very soon.